sensitivity to ionizing radiation. So we said the most sensitive tissues within our bodies, the examples we gave as the red bone marrow, the gonads, the colon, stomach, the lungs, and the breast as very, very sensitive tissues within our bodies to radiation. Then the medium category of tissues that are sensitive to ionizing radiation within our bodies are things like the urinary bladder, the liver, the esophagus, and the thyroid. Then the least sensitive tissues within our bodies are, for example, the skin and then the brain tissues. So that is a brief recap of what we had started on. We also went as far as defining what radiation protection is as a term applied to those concepts, requirements, technologies, and operations related to protection of people against the harmful effects of ionizing radiation. And particularly, our interest is to become familiar with the basic safety standards requirement for medical exposures. We are going to define what medical exposure is, but for the meantime, these basic safety standards requirements that we want to address is justification, optimization, and diagnostic reference levels. So these BSS standards are going to form the background of what we are going to discuss. Joseph Muonge, can you turn off your video? Joseph Muonge and Paddy, turn off your video.
My video is off, doctor.
Sure.
Yeah, it has been off. Maybe someone else.
Okay, I'll need to check that. Okay, fine. So let's move on and see what this issue of radiation protection is all about. As a matter of fact, we all know patients get exposed medically as part of their diagnosis or as part of the treatment that they should undergo. And these kind of exposures have to be regulated in a way, because if it is not, then we may end up injuring a number of our patients. So we have a number of organizations, international level and national levels, that formulate guidelines on how we should use radiation in the best way possible. One of them is the International Commission on Radiation Protection, then the basic safety standards, which they have spelled out some principles that we should follow to help protect our patients, and those ones are what we have already pointed out under justification, optimization, and diagnostic reference levels, or DRLs. So generally, how do we categorize radiation exposures? We can have three broad categories. That is the medical exposure, then the second broad category is the occupational exposure, and the third one is the public exposure. But in this discussion, our main focus is going to be on medical exposure. If I make mention of occupational exposure at some point in time, it is just being mentioned in passing. The same for public exposure, but our main focus is medical exposure. So what exactly is medical exposure? Because it is the one that we are looking at it in relation to the BSS that we have mentioned, that is justification, optimization, and the DRLs. So medical exposure has basically three broad groups that we look at. One of them is exposure of persons as part of their diagnosis or treatment. So basically, we are referring to the patient, that we expose our patients as part of their diagnosis or treatment. Medical exposure also includes exposures incurred knowingly and willingly by individuals such as family and close friends, helping either in the hospital or at home in support and comfort of the patients. So those caretakers, when they get exposed to radiation while helping the sick, their sick relative, knowingly and willingly, we also categorize them under medical exposures. Thirdly, their exposures incurred by volunteers as part of a program of biomedical research. So, for example, if one of you developed a research proposal, and in that research proposal, you're going to expose your participants to ionizing radiation. Those participants in your study, the exposures they are getting is categorized under medical exposure. So that is strictly what medical exposure is. Let's now look at the BSS, those basic safety standards of justification, optimization, and diagnostic reference levels. Along with diagnostic reference levels, at some point in time, we are also going to introduce a fourth term, which is going to be called the dose constraints or the dose limits. We shall start with justification. What exactly does justification of a medical exposure mean? We're saying that the decision to adapt or to continue any human activity involves a review of benefits and disadvantages as well as possible options. This scenario can also be applied to our usage of ionizing radiation. Literally, what justification is saying that we should weigh the benefits against the disadvantages of exposing our patients to ionizing radiation. And while we're doing that, we should also look at other possible options. For example, here we are saying choosing between the use of X-rays or ultrasound scan in our patients. So in this case, if during the process of weighing this, we realize ultrasound scan will still give us an answer after all, then the choice we shall go with is definitely going to be the use of ultrasound scan while sparing the patient the use of ionizing radiation in the form of X-rays. But also the catch is that often the radiation detriment will be only a small part of the total detriment. So you also have to keep that at the back of your mind And how do we get to judge? How do we get to know that the benefits outweigh the disadvantages? One of them is based on our experience, then professional judgment, and of course, common sense. Yes, Timothy, you can unmute and ask your question.
What does the second bullet mean?
Which on the slide?
Yes.
So what it means is that sometimes we are so engrossed in the idea that radiation causes injury, while we ignore the process of administering this radiation to the patient. So we might think radiation injury, and yet the injury due to radiation itself is very small, but the process is the one which is more of a disadvantage to the patient. So we also have to factor in that, because sometimes that is how our judgment goes wrong. So we are talking about how we get to this issue of justification, and we are saying it's made on the basis of experience, professional judgment, and common sense. What we mean here is that you have to be clear with the indication why one should get exposed. And you remember when we looked at the rationale for requesting for an imaging examination, we clearly pointed out first as indication must be clear. And again, here we are emphasizing how it is even very important when it comes to exposures to ionizing radiation. There are three levels of justification. One of them is the general level, where the use of ionizing radiation in medicine is accepted as doing more harm than good. You can think about it globally. Every unit, if you go to different parts of the world, you will find there is at least ionizing radiation being used in medicine, because there is a global consensus that the use of ionizing radiation in medicine is doing more good than harm. Then there is a second level, which is the generic level, where we're talking about a specific procedure with a specific objective. This is where the issue of indication for exposure comes in. And it's only you as a professional who can make this justification. Where we're saying, for example, chest radiographs for a patient showing relevant symptoms. A layperson cannot filter out these relevant symptoms in order to recommend or prescribe an exposure to ionizing radiation. But for you as a professional, you are trained to do that. Then there is the third level, that is the application of the procedure to an individual patient. So again, this now narrows down or moves down to the imaging department. So for you as a general clinician, you are embedded within here. But now when it comes to us, the imaging professionals, then we have to also carry on with the third level. So that is it about justification. Once we have justified that this exposure is beneficial to the patient, then it takes us to the next step, which is optimization, where we are really emphasizing that everything should really work well for the patient in terms of equipment and the procedure. So everything should be optimal for the patient. We are saying the equipment should be a safe one. It should be installed properly. Then the procedure should be carried out on the patient safely. And above all, while we are carrying out this procedure, we have to keep at the back of our mind that the radiation dose that we are going to use on that patient should be as low as reasonably achievable. But it should not compromise on the diagnostic quality of the study or the images that we shall produce. So the key thing in optimization is that we must use a radiation dose that is as low as reasonably achievable, but it should not compromise on the quality of the images that we shall produce, or it should not compromise on the results of the study. And this, as low as reasonably achievable, sometimes it is abbreviated as ALARA, A-L-A-R-A. It's all, if we maintain this or if we optimize this, then we can easily achieve that goal. So optimization of protection in diagnostic radiology, it does not necessarily mean reducing the dosage to the patient, because there are instances when we may actually increase the dosage because we want to maximize on the quality of the study. Because sometimes just reducing the dosage may end up compromising on the study or the examination that we want to produce. Or if we keep on reducing to critical level, then it may begin requiring other extra resources that may not be easily attainable. That is to do with optimization. Once we have achieved that, then it takes us to the next stage, which we are talking about as diagnostic reference levels. So diagnostic reference levels is like a guide. It's like just a guide. So it gives us an idea of where we should be falling when everything is optimized, and the justification was clear. So by definition, diagnostic reference level is a value of I'm going to go offline for just about a few minutes, a few seconds, and get. We are looking at the definition of diagnostic reference level as a value of dose rate, or activity selected by professional bodies in consultation with regulatory authority to indicate a level above which there should be a review by medical practitioners and medical physicists in order to determine whether or not the value is excessive, taking into account the particular circumstances and applying sound clinical judgment. So we said it's just a guide. For example, let's think about a patient who is meant to undergo a plain chest radiograph. There are ranges of radiation doses that patients who go or undergo chest radiographs receive. There is a range, an acceptable range. So those ranges are usually formulated by those professional bodies, and then we, the local institutions, also adopt them and use them in our practice to ensure that we don't expose our patients to excessive amounts of radiation. And we can only ensure that if every patient whom we examine have the dosage falling within the range that we have adopted. If, let's say, we make a survey and we realize that the dosage that our patients are getting is way beyond the range that we have adopted as acceptable, then there has to be what? Some form of investigation or a review to understand why we are going beyond what we have adopted. And we are doing that with a view of knowing whether there is a sound clinical reason why these patients are getting more than necessary, or there is not. So if there is not any scientific reason why it's happening that way, then we have to know the reason for that. Is it because the technicians or the imaging workers that we have are not adequately trained and they need proper training? Or is it the equipment that we're using which is faulty? It is giving excess of the radiation to the patient. That is the reason for these diagnostic reference levels. We are talking about reference levels or range because patients have no radiation dose limits. The patients don't have any limits. What governs how much radiation we should give to a patient is the issue of justification and adherence to diagnostic reference levels. So with the justification, as long as we still feel there is benefit, the patient is still going to derive benefit from the exposure, we don't stop the patient. We still go ahead and recommend. But the moment we have the justification that there is no more benefit, that is where we stop. So, yes, we have already talked about corrective actions that should be taken if doses or activities also fall substantially below, because in that case, the quality may be affected. While we mentioned the diagnostic reference levels, there was that fourth area where I mentioned about those constraints or those limits for medical exposures. What does those constraints mean? We said dose constraint is synonymous with dose limit. So in this case, we are asking ourselves that in which situations do we apply a dose limit or dose constraint instead of diagnostic reference levels? Because the two are different terms. For DRLs, we said it is just a range. It's just a guide. But this time, for those constraints or those limits, it's like a red line. It's like a red line that don't go beyond this red line. Just like you have it in theater, you always have those marks on the floor that leave your what? Your other clothing and shoes here. Beyond this area, you have to be in a theater gown. That is what those constraints or those limits is here. That beyond this level, you're not going to be allowed to go as you were. And in medical exposure, when is it applicable? In medical exposure, it is only applicable in two situations. One of them is the caretaker of the patient. Remember, we said they were part of medical exposure. Then the second one is that volunteer in biomedical research. So it means if, for example, a caretaker, we have been taking records of exposures that the caretaker is receiving, there is usually a limit. We shall keep on reading the dosage. Let's say if nationally in Uganda, it is recommended that a caretaker should not receive more than 1 millisievert in a year. So if you've been taking care of a patient in a radiation environment and your dosage has already reached 1 millisievert, it means that caretaker is going to be asked to leave and be replaced by another person. The second situation is in biomedical research. If in your protocol, in your study protocol, you had said your participants are not going to get exposed to more than, for example, 10 millisieverts during the study process. The moment any participant reaches 10, that is the end of the road for that participant. You are not going to be allowed to carry any further exposure to that participant. That is, those are the two situations when those constraints or those limits apply in medical exposure. But for the case of the patient, it is DRL or diagnostic reference level that apply to him or her. Let's now move away from that, because as we had mentioned, we were just looking at it on the surface, not going deep. Let's look at what is more practical. Methods of patient care in a radiographic environment. These ones are a little more practical than what we have just discussed. For example, one of them we're saying that avoid errors, right patient for the right examination. This is very key information, both to you as a general clinician and to me as a person in the imaging environment. We are emphasizing that give all the necessary information about the patient so that the right patient undergoes the right examination. Just imagine if you were writing a request form for a patient called Alex. And in that request form, you forget to specify the area to be examined. And the patient carries that request form to the imaging department. Your interest was to do a chest radiograph, but you have not indicated that you need a chest radiograph. And Alex is a patient who has a link to the imaging department, and the technician sees Alex limping and thinks he came because of that limp, and yet your interest was the chest. That is already an error. The second way these errors can easily come is basically documenting those biodata of the patient. Just imagine, because you came with all the frustration from home, this time you have decided to write only single names for all the patients you are seeing. So you're writing only first names for every patient who comes in. Yes, Peter, raise your question. Peter? And take Peter, unmute and ask your question. And take Simon Peter, I see your hands up. Okay, I think let's move on because I can't hear anything from
Yes.
Peter. Yes, please.
Let's move on, Doctor.
Okay. So again, if you're writing only those single names and you've ended up with 3 patients bearing their request forms with the names John, and all the 3 Johns went to the imaging department, and just imagine the technician is not keen on which John is which. So he's going to call in John, and definitely the quickest John is the one who is going to enter into the imaging room. So if the quickest John was for a knee X-ray, and yet the actual John you want is the one who has gone for abdominal X-ray, you can see that the John of the knee now gets exposed for the abdomen. That is a big, big error. So just ensure you provide all the necessary information, just like in the imaging department. We also try as much as possible to avoid these kind of errors by ensuring that the right patient undergoes the right examination. Avoid repeated exposures. Again, it can start from the clinical room and continues all the way to the imaging department. Just imagine if Madame Rose yesterday went to facility A and had an exposure done. And along the way, somebody tells Madame Rose that there is a very good doctor in facility B, which you may need to see because of your problem. So she'll come with her film from yesterday's exposure smartly tucked in her bag, then comes to you in facility B. And during your interaction, you realize there is need for such an examination. Then again, you ask for rows to go and get an exposure. But you would have avoided this by just asking if previously such things were already done. She may just avail that information for you right away. We will have avoided a repeated exposure for that patient. It can also happen in the general department where you are if you're not working as a team. For example, if there is a problem between Paddy and Tege, John, that they don't think each of them is professionally competent enough, and yet they have to work as a team. So Paddy does not read Ntege's recommendations in the file, just like Ntege also does not read Paddy's recommendations in the file. So if yesterday it was Ntege on duty recommended an exposure or an examination for the patient involving exposure to ionizing radiation, the patient went and did. Today it is Paddy on duty, but because he doesn't take it seriously, he also comes and writes a fresh request for the same patient. The same patient will go for the same examination. It is a repeated exposure, which is unnecessary because that is a very short time frame. Probably nothing has changed from what it was yesterday to what it is today. That is again the way it can happen. For us also in imaging department, it can happen. Just imagine we have employed that person who is not professionally trained, who is not competent. So during the process of examining these patients is basically doing a trial and error on the patient. So he positions the patient, takes the first image with a set of exposure factors. The images come out, let's say it is underpenetrated. So the next thing, gets back the patient, steps up the radiation a bit, exposes the patient. It is again overexposed. It is not diagnostic. Gets the patient back for the third exposure, comes back midway between those exposure factors, exposes the patient again. This time the images are diagnostic. Those are two unnecessary exposures for the patient because of somebody who is not competent in his or her job. So we have to avoid that by ensuring also in the imaging department, we have people who are professionally trained and competent. The third thing that we can do, which is practical enough, is collimating exams. Collimation simply, we are referring to limiting the radiation exposure to only the area of interest. Limit the radiation to only the area of interest. So if the request form says we want our patients to have a chest radiograph done, there's no point in opening the radiation beam so wide that it should also include the patient's head, because the head is not part of the requirement. So we shouldn't get radiation to that area of the body. And we can only do that by collimating the examination. So in those imaging equipment that use ionizing radiation, there are diaphragms. They are structures which are like diaphragms that help us to control the size of the beam which is emerging from that equipment. And those diaphragms are called collimators. So we adjust them to the size that we want. Away from that, let's keep the issue of the eye kilovoltage technique because it is not very useful for your level, and we look at time, distance, and shielding, TDS. The first one is the issue of distance, and with distance here we are referring to the distance or the gap between the radiation source, be it X-ray or a radioisotope, etc., the distance between it and the patient. For example, in radiography, the minimum distance we put the patient away from that X-ray tube is about 40 inches or 1 meter. 40 inches is approximately 1 meter. We do that because we are trying to limit the dosage of radiation which is being deposited on the patient's skin surface. That is the reason. There are many other reasons, but in this context, the key reason is to limit the dosage of radiation being deposited to the patient's skin surface. What about the issue of time? Bullet 2 addresses the issue of time. We always want to use imaging receptors or recording mediums that respond very fast to radiation. They respond very fast to radiation. If you use imaging receptors or recording mediums that respond very slowly to radiation, it means you have to keep the radiation running through the patient for a much longer time. Whereas if you use a faster one, it is going to detect it very fast and record the information also very quickly. So the radiation runs through the patient for a much shorter time. Lastly, the issue of shielding. And for the case of shielding, the commonest we use is lead. So there are many pieces of lead designed to protect the sensitive areas, and we usually recommend that they be provided to the patient to cover the areas which are not necessary to be exposed, or the areas that we think are very sensitive, and we have already pointed out some sensitive areas within the body. So that is it about radiation protection. Our next area should have been radiographic positioning terminologies, but I would want to leave these ones to you guys to first read on your own, then maybe we discuss it at a later date. I want us to start looking at something else. So take note of this and try to look it up on your own. Where you have not got it clearly, you let me know. I want to project something else. But before I do that, let me see. the number of questions which are in the chats. Let me see them. There is one from Pauline which says, where does radiation to reduce tumor size lie? That is a patient who is undergoing treatment, isn't it? So that we are looking at the treatment arm of radiation. So there is no other special place where it lies. Somebody is asking about BSS and ICRP, which we have already mentioned that. Somebody has defined it here. Then, okay. So let me share something else. So this is meant to be our next part of the introductory session, which captures the principles or the basic principles of radiological interpretation. I'm going to be a bit fast through it because most of the things that we are going to mention here, we have already discussed them in the previous presentation. So one thing is, where can you look at images? Images come in different formats depending on the resource envelope of your facility. So some facilities are purely digital, others are analog because they're still as poor. For the case of the digital facilities, there is what we call the picture archiving and communication systems, which are a network of computers or workstations which are interlinked within the facility, where you can access all the patient's informations, including the radiological exams. Then there are those ones which are internet-based or web-based, like the second and the third ones. And for the case of these ones, it means you can even work or provide your opinion when you are out of station. You just need to have access to internet and as well as have the software being used by your facility installed in your computer, your personal computer, so that you can just log in and provide your opinion. The poor facilities, of course, analog, we have those films that we hang on our viewing boxes in order to make our interpretations. What are some of the viewing conditions? You need a quiet dark room with a little or no distractions. If you're using the viewing boxes, at least 2 well-lit viewing boxes. Those viewing boxes have to have proper illumination, which is uniform. And when you're looking at those images, keep at the back of your mind that the 3-dimensional concept is very important. You may be looking at a 2-dimensional image, just like a plain chest radiograph, maybe just one projection. But you also have to know that that structure we're looking at has a 3rd dimension. If you can't If you can't recreate it, then you can go ahead and do further imaging by doing another projection, which is at right angle to the previous one. So the commonest that you already know about is the issue of epilateral. Reason being that you're trying to recreate the other third dimension, which is missing from the first image. So the first image was the epi, it's two-dimensional. Then you've done the lateral to give you the other missing third dimension. Another one is, of course, you have to have reference materials in the forms of text, sometimes models that aid in your interpretation. This is just an illustration of a workstation displaying a radiological image for some patients. Then when it comes to looking at your radiological study, there are a few things that you may want to reflect on before you even make or communicate your opinion. One of them is the adequacy of the study. And these are simple, basic things that that study you're looking at should have. One of them, for example, is the study you're looking at correctly labeled. Is it having the patient's names? Does it have the side markers indicating this is left, this is right? And then does it have the date when the study was done? Those are key information. Then the other thing, still under adequacy, you querying your image whether technically it is worth reading. So, for example, we pointed out the issue of collimation. Is it a well collimated study? If it is not, then sometimes it has already lost significant resolution. So you may miss out a number of things. You're looking at the presence or absence of artifacts, because those artifacts may mimic a pathology that doesn't exist, or may actually obscure a pathology that exists. So it also has to be technically adequate. And when you now think the study is adequate and you're doing the actual interpretation, then you have to be systematic and at the same time focused at the study. Systematic, we mean that you have to have your own system that helps you to look at each and every thing which is displayed on that image. If you don't have a system and you just do a random check, then you're not doing a good job. You're going to miss out a number of things. So we're saying you have to be both systematic and focused. The focused bit, we are saying you should correlate your reading with the clinical information that you have been provided. So if the clinical information says we suspect a lobar pneumonia in this patient, it means much as you're going to look at the thoracic cage, you're going to look at the mediastinum, you're going to look at the lung fields. Your major focus is going to be in the lung fields at the end of it all, because they are suspecting a lung consolidation. The last bit of the advice is that you should try as much as possible to look at the images first before you run to the report that has been availed to you. Why? Because sometimes you might discover something extra about that study. And if that is a situation, there is usually room for you to communicate back with the person who wrote the report, so that you iron it out and you're able to help the patient better. Sometimes you may come with a completely different diagnosis from what the report has. Again, you can always communicate and address such an issue so that the patient is again helped better. These are just examples of diagnosis. It's not very useful for now. It might be a pneumothorax, a pneumonia, pleural effusion, small bowel obstruction, or free air in the peritoneal cavity. And also, if the patient already has some devices attached to the body, you must always evaluate them. For example, there is an NG tube in place, you must ensure it is in the right place. There is a chest tube, you must ensure it is in the right place. There is an endotracheal tube, also make sure it is in the right place, or there are cardiac electrodes. You have to ensure it is in the right place when you are making comments on such images. So the radiograph. We talked about the technical quality and the adequacy of the study, and we have mentioned examples as collimation. There are still others like exposures, and then artifacts. Then if you've done that, at the end of it all, the study may be normal, it may be abnormal, and if it is abnormal, then you have to be as specific as possible to what you think is abnormal. Avoid hanging things unless you don't have hanging diagnosis, unless you don't have adequate clinical information. If what you're seeing is also just because of an artifact, you have to state it clearly. Viewing those radiographs, I am sure most of you guys have interacted with radiographs on the wards a number of times, and when you're hanging them on the viewing boxes or holding them up on the sun rays, the advice here is you must observe anatomical positioning that you were taught in the preclinical class, especially when it comes to AP and PA, as well as the obliques, where we usually emphasize that the left side of the image should be on your right, and the right side of the image should be on your left. That anatomical positioning is still key in imaging. Also, we observe that convention a lot. The 5 radiographic densities or shades of gray, there's nothing new here. We have already looked at them. So let's not spend our time on it, how they appear. And we already mentioned that if it is just a plain radiograph, those are the only 5 you have to deal with, and they represent the pathology as well as the normal structures. So you must know the normal radiological anatomy of the structure you're looking at. Then evaluating it, I've already emphasized that take into account the patient's clinical history and the clinical signs. Those are very important things. If you don't have them, then you cannot make a proper diagnosis. Medical imaging is not some kind of magic that you'll always provide the diagnosis without the patient's clinical history and clinical signs. Just like how you now see that the person who does the interpretation also has the same background training like what you are going through. If an abnormality exists, I've already said you should be as specific as possible. And by being specific as possible, you have to state exactly what the abnormality is and where it is. For beginners, we usually take you through the raw antigen signs, which help you to formulate what you're seeing, so that you're able to later on summarize it and conclude appropriately. So what are those raw antigen signs? They are not anything so new because they're similar to what you do in clinical practice. So if you've seen an abnormality, you're asking yourself a few questions. What is the size? What is the shape? What does the margins look like? What are the numbers? Is there any change in position of maybe structures? Is it just an alternation in opacity? Or what I'm seeing, is it just a change in function of the organ? This is what we are likely to encounter, and each of them communicate a very important message to you as a clinician. For example, size alone will give you an idea of how much derangement in function has occurred. Shape may give you an idea of how aggressive the pathology you're looking at is. Margins still again gives you an idea of the aggressiveness, because for example, if the margin is ill-defined, then you know it's not something which is very innocent. It's something which is aggressive, unlike something with a very clear margin where you can pinpoint the normal structures and the abnormal. Numbers, again, still very important information for you as a clinician. For example, you're seeing these numerous masses in a patient's lung, then it's communicating to you something that probably what you're seeing are metastases from another source. Unlike that single mass in the lung, which is most likely going to be a primary problem in the lung, change in position may be the only thing you'll see on that imaging, and it communicates again something is not right. For example, we have looked at these patients with, let me give a simple example of COPD, emphysema. One thing that we look for is the change in position of the diaphragms, because these patients suffer retention of air in their lungs. So the diaphragms get depressed and depressed. So it means the diaphragms are going to change their position. Or another simple example is this trauma patient who has presented with a tension pneumothorax. So there is that ball valve mechanism which is allowing air into the pleural space and not letting it out. So it is going to change positions of structures. For example, it will depress the diaphragm, it will push the mediastinal structures to the opposite side, and you see these very large thorax on the affected side. So that is what you may see. Alternation in opacity is, again, something that you may see in another patient. For example, you met this patient with the acute onset of cough, fever, pruritic chest pain, and you think there is a pneumonia. On doing the radiograph, you find the lung is looking white, and yet from your basic knowledge of radiology, the lungs look black. So that is an alternation in opacity, indicating to you that there is a pathology. Change in function of organs. I'll give a simple example. If, let's say, patient A comes with a complaint of difficulty in swallowing and maybe accompanied with the pain, then you decide as a clinician that you're going to do for us a barium swallow, for that matter. You're going to do for me the barium swallow. We all know the function of that esophagus is to convey materials from the oral cavity down into the stomach. So the patient is given barium to swallow, but during the study, you see that the barium remains hanging maybe somewhere along the esophagus. That is already a change in function. It can no longer convey that barium from the oral cavity down into the stomach. So these seroantigen signs are just to help you formulate your ideas as you look at that image. So you can use it if you think it is useful, or you can formulate your own ways of appreciating some of those pathologies. When we are making interpretations, there are, of course, pitfalls that we may suffer, and we have to point them out now so that we don't become victims. One of them is getting distracted by a large lesion, and we forget to look at the rest of the images. So the patient has brought for you an image, and what you've seen is that very large pleural effusion, and you forget to look deeper into these images, and yet if you looked deeper, you would now be asking yourself what has caused this very large pleural effusion. There may be actually a mass in the lung also visible within the same image. So don't get taken up by those very large lesions, and then you forget to do a general look through the entire image. The other issue is the tunnel vision. Sometimes we only want to think within the box and not outside the box. So because the patient was yes to all the B symptoms that you asked, and you've been told, oh, these B symptoms are basically for TB infection. Then you fail to know that there are also other possible differentials to this kind of presentation. That is something we should avoid, because despite all the VB symptoms, it may be some other pathology. And we're summarizing it by saying that if you remain systematic in your approach, you are less likely to go wrong. So start formulating a system that helps you to exhaust everything which is usually demonstrated on any image that is provided to you. So that is it about our general principles when we have to interpret some of these images, and it applies to almost images from all these modalities. And now specifically, I want us to address ourselves to computed tomography. We have already introduced ourselves to the basic ways in which it functions. We also mention some of its strengths and some of its weaknesses. CT, yes, Paddy?
Yes, doctor, thank you so much. When we were in third year, we were rotating a mode, and they taught us about interpreting X-ray, something small. Those things of penetration, art, and everything. So are we going to go into those details when we are doing specific radio imaging modality to go through all that? Because I've seen you have covered that part of interpretation.
Yes, what we're covering now is just general, but time will come when you will begin looking into individual body systems, and when you get into those individual body systems, there's going to be a little more detail about what you are asking about.
Okay.
So yes. So let's turn our attention to CT. Again, it's going to be a general approach, not really a detailed thing. So CT, we mentioned very many things already about it. And when we weigh it against plain radiography, we said in plain radiography, we only have 5 shades of gray that you have already looked at. But for the case of CT, the shades of gray are much more. They are in thousands that your eyes will be able to appreciate. And when it comes to CT, yes, there are still some other terminologies that we borrow from plain radiographies. Then there are also other terminologies which are a little more restricted to CT images. So these are some of the common terms you'll come across, so you'll use when you're dealing with your CT images. One of them is attenuation. We already mentioned attenuation when we were having the first introductory session. And attenuation here, we are still holding on to the same meaning that different structures within our bodies are able to block the X-ray radiation and transmit others to different degrees. Others will block more and transmit less. Others will block less and transmit more. And we said for areas that transmitted more to the detectors, the areas on that film will look black. The areas that will transmit less will look whiter. It still holds also for CT, and those other principles, those other physical reasons that we mentioned, the effective atomic numbers and the rest still apply here. So you'd come across reports talking about maybe, for example, a lesion of low attenuation. Low attenuation, meaning the lesion is darker than its surrounding. Or somebody is talking about a lesion of a higher attenuation, meaning that it is what? Whiter than its what? Surrounding. That is how the issue of attenuation comes in. Closely linked to attenuation is the issue of density. Density in computed tomography, we can use it loosely as relative terms, or we can use it objectively when we go on to measure the CT numbers or the Hounsfield units. So when we're using it just loosely as relative terms, you'll hear terminologies of hyperdense, hypodense, isodense, or mixed density. These are just how we see things. So if it is hyperdense, it is whiter. If it is hypodense, it is darker. If it is isodense, it means it has the same density as its surrounding. If it is mixed density, then it has a mixture of hypo, iso, and the rest. We have said density and attenuation are very closely related. So it means if we're saying something is hyperdense or a lesion is hyperdense, it also means we can say it is a what? A lesion of high attenuation. If we speak such words, we are basically talking about the same thing. Or somebody says it is hypodense, literally meaning we are also saying the lesion is of low attenuation. So if you find them being used, you should be flexible with them because we can use them interchangeably. What comes next is the issue of enhancement. Enhancement, we apply it strictly when we are referring to studies which are done with and without contrast. When we do studies with and without and with contrast, it means we want to see the behavior of a particular pathology going on in the patient. Let's say, for example, the patient has a liver mass, and then we do the first scan without contrast. After that, we administer contrast to the patient and then repeat the scan again. So we have two studies of the liver. So what our interest is, we want to see whether this mass in the liver takes up contrast or not. If it takes up contrast, it means it is going to change and begin looking whiter than it was before the contrast. If that is what happened, then we say it has enhanced. If it has remained the same, then we say it has not enhanced, or it is a non-enhancing liver mass. We can quantify this enhancement by measuring the density of that lesion without contrast and compare it with the density after contrast. So for example, the density may be 40 Hounsfield units before giving contrast. Then after contrast, it moves to, let's say, 80 or 90 Hounsfield units. So it has enhanced. That gives us an idea of perfusion within that lesion, and we can still use that idea of the perfusion to deduce that it is either an aggressive mass or it is not. Away from that, we have talked about the density that we can quantify it, that we can assign objective figures to them instead of using hypo, iso, and the rest. So CT numbers, again, or the Hounsfield units, means we have put all the body tissues along a spectrum, just like we did for plain radiography. Or let's think about it like a number line, where we have 0 at the center and the negative side of the number line and the positive side of the number line. So when we spread all the tissues within the body along that number line, we shall have structures with negative Hounsfield units and those ones with positive Hounsfield units. For the case of CT, our reference density, which is not a true density, is assigned to pure water. So water on CT treats it as having a density of 0. That is very clear water without any impurities in it. And on the positive side, we have many other structures. For example, soft tissues with their densities within this range, bone contrast within this range and higher, then metal even close to thousands. Then on the negative side of 0, we have fat, usually in the range of negative 100, until you reach the extreme of the negative, where we have hair with the density of negative 1,000. So that is how CT looks at those densities and the Hounsfield units. You don't need to really start cramming all these figures because they are ranges. For example, in real practice, somebody will tell you from maybe negative 25 onwards, it is fat, until maybe you reach like 500. Beyond that, it is a gaseous medium or an area containing some air. So don't really try so hard to cram these figures. They come with time, and when you are interpreting the actual things with all the clinical information, it is much clearer. That is what we have for CT. We have here an illustration of axial CT scan of a patient's head, just at the level of the pituitary fossa. This is a trauma patient, and we want to look at some of those things that we have talked about. We said air is black and the density is negative 1,000. So you measure maybe 900 something, 600 something, that is a gaseous medium. And within this aqueosity of the head, there are areas where we expect, of course, some gas or air, like in the paranasal sinuses here, if you're looking at these ethmoid sinuses, and you can clearly see it looking black, but or hypodense. And if we were working on a workstation, we can easily measure. We can easily measure this, and it will give us something very close to this figure. So that is what the arrow is pointing to. But since we are saying this is a trauma patient, something wrong also happened. And we can see that in the cranial cavity, there are also those black dots, which had densities within this range, meaning this patient has some form of a pneumocranium. So there's some air has entered into the cranial cavity following the trauma. Then the next one is water. Water, which is the closest in the cranial cavity, is CSF. So it's also hypodense, but when we measure the Hounsfield units or the CT numbers, it's going to be closer to that of water, because we know there are other metabolites in CSF. It's not going to be 0, but it is going to be close to 0. So you might get something in the range of 0 up to 10, or sometimes even almost to 15 Hounsfield units. That is water. It's what it is communicating to you. So this is part of the lateral ventricle. What about bone? Bone is of a higher attenuation, so it lies on the positive side of 0, almost close to the extreme. So it looks as white as we are seeing the cranial bone right there. If we measure it, we might find something within that range. What about the brain tissue itself? Is what we're seeing with the looking that gray, and the densities usually fall within 35 to 50. And lastly, let's look at the clotted blood. So what we're seeing here, this white area, of course, visually it is indistinct from the bone, but as we said, we have that extra edge of being able to measure the density. So if we measure the area of this white lesion here, it's going to be in this range, and that is an acutely clotted blood which is still an acute clot. So that is it about computed tomography. The other one is magnetic resonance imaging. Again, we are going to address some of the common terminologies or terms in MRI. For the case of MRI, we said we don't use ionizing radiation, but what we use there is the radio frequency waves. Yes, Alex?
Good morning, doctor.
Yes, how are you?
Good. I would like you to comment about the fresh hematoma and the clotted blood within the cranium, its appearance.
I comment on
the appearance when the hematoma is fresh and clotted one, or the clotted. Yes, the appearance.
Okay. Fine. Thank you. I intentionally ignored it because I know it's going to come up when you do imaging of the CNS, but since you already want to have an idea, a hematoma per se is already blood which is outside the vascular system. Okay. That blood outside the vascular system will go through a number of changes in its consistency. The first thing for it is to clot once it is outside that vascular system. And when it has just clotted, let's say for the first 1 to 7 days, that is what I'm referring to as an acutely clotted blood. On CT, it looks hyperdense. Okay. After these about 7 days that we have mentioned, that blood begins to break down. It begins to liquefy, and then some of the materials that made up the red blood cells begin to get absorbed back into the circulation. So it will reach that stage which we call the subacute clot. So this subacute clot, after 7 days to about 14, in the brain, it will look isodense. It looks similar to the brain. Okay, so you cannot easily distinguish it from the normal brain. So a subacute clot is isodense to the brain tissue. Then after these about 14 days, we still have that process of breakdown taking place. After those 14 days, it now begins taking more of a water consistency. So we begin talking about the chronic kind of clot or a chronic hematoma. And this chronic hematoma is going to look now hypodense. So it is going to look as dark as almost this CSF which we have here. And if we measure the density is going to be closer to the density of water. That is the process, how it goes through. Blood which is still within the blood vessels, and it is not clotted, it is usually gray. It looks similar to the other soft tissues. So in the brain, it will look basically like the brain tissues. You can't differentiate it. So we are not talking about that one. We are talking about blood which is outside the vascular system. Let's get back to MRI. And we were looking at the common terms. We said because we use radio frequency waves, we can't talk about densities and the rest. On MRI, the preferable term is signal intensity. So the loose relative terms for signal intensities that you come across in MRI is high signal, low signal, or intermediate signal. Or you'll come across hypointense, isointense, hyperintense, or mixed intensity. So hyperintense lesions, hypointense lesions, mixed intense lesions, iso and hyperintense, or a lesion of high signal intensity, a lesion of low signal intensity, and the rest. That is how signals will come. Yes, Jonathan?
Right. Thank you, Dr. Moses. I wanted to ask you briefly before you proceeded if there is any way the management of a patient can be influenced by ordering of either contract or contrasted or non-contrasted CT scan, because there are times when a clinician asks to look at both of the CT scans in one patient, and then there are other times where probably one of the two scans is requested for.
How the use of contrast influences the management. The use of contrast, we use it more of as a diagnostic aid. It supplements on the information that we can derive from the patient's scans. For example, there are situations when the use of contrast is mandatory. For example, if we are suspecting an inflammatory process, the use of contrast is I would say it is mandatory. The second situation is, for example, we are suspecting a tumor, a neoplastic process. The use of contrast is, again, something which is mandatory. Why? Because contrast adds more information about the behavior of the lesion that we are seeing. For example, we might be suspecting a neoplastic process in the patient, and we scan the patient without contrast, and the lesion is isodense, okay? It looks like it's surrounding, but our interest is really to delineate it so that we are able to judge the size and also be able to narrow down our list of differentials. So if it was isodense in the first instance, then we go on to give intravenous contrast, and then this time it lights up. It lights up, it is looking very bright and homogeneous, okay? It can, now we can ably measure its size. Secondly, basing on that pattern of enhancement, we can narrow down our list of differentials. So that is how contrast would really influence your management of the patient, because this time you have a smaller list of differentials, or you even have a definitive diagnosis already because of its behavior with contrast. The second situation, just think about this patient who has presented with a cerebrovascular accident. There are those that we don't go ahead and give intravenous contrast. Then there are those that we go ahead and give intravenous contrast. So if after the scan without contrast, we are seeing this patient as presented with, for example, subarachnoid hemorrhage, There is collection of blood in all the subarachnoid is that there is a ruptured aneurysm. We can only demonstrate that aneurysm by giving the patient intravenous contrast. Without it, we won't see a way it will affect your management, because once we have given contrast, this time we are able to see where the aneurysm is, and the neurosurgeon can now plan appropriately that, this is how we are going to approach it. From this area, once we reach there, we are going to clip it like ABC and come out of the patient's head. Yeah. I hope that answers your question.
Yes, it has answered the question. Probably it will just find out more indications of the different CT scans, like the non-contrast that you haven't talked about briefly.
Yes, right now we are just looking at things at individual body systems, respiratory system, GIT, musculoskeletal system, and the CNS. That is when things are a little more specific. For now, it is not. Okay.
Thank you. Yeah, thank you.
All right. So back to MRI, we were introducing those signal intensities and how we can play about with our terminologies. So when we are talking about those various degrees of signal intensities, we talk about it while also keeping at the back of our minds how the images were acquired, what sequences were used to acquire those images. Because in MRI, we don't have that luxury like we had in CT, that we can measure densities. In MRI, we cannot. So the only thing we can do is to acquire the images using different sequences, so that from those different sequences, we are able to generate different types of image appearances. And we base on that to make our interpretation. So what I'm literally saying is images acquired using a T1 weighted sequence, for example, will look different from images acquired using a T2 weighted sequence. That is one general rule. There are many other sequences that you'll get to hear about. So we base on that to first of all help us understand what is going on in the patient as we describe the behavior of the signals. With MRI, we also use intravenous contrast. For the case of CT, the contrast we use there is iodine-based. They are developed from iodine. But for the case of MRI, the contrast agents are gadolinium-based. They are developed from gadolinium. So when we do studies without and with contrast, we also talk about enhancements. And for the case of MRI, contrast is only given to images acquired using T1 weighted sequence. They don't give contrast when images are being acquired using T2 weighted sequence. There are many other sequences that you will come across. So we have here an example of an image taken from low down. It's an axial image low down in the patient's pelvis. So you can see that there are other areas which have high signal, for example, this bright subcutaneous fat here. Then you also have on the anterior aspects, this bright subcutaneous fat. Then what we're seeing right here is a cross section of the urinary bladder. And we can again see that the urine within that bladder cavity is also of high signal. It is bright. And the rest, like the bladder wall, more of intermediate signal. These are just muscle still intermediate signal. But again, here we have this area which is a little brighter. That is also fat within the bone marrow. It's part of the pelvic bone. Don't mind about whether if you can't really appreciate that this image is from the pelvis, because we are still growing up. But by the time things get a little more obvious. So there are ways we can begin to even apportion or assign signal, sequences of acquisition to images just by looking at the behavior of tissues like this, which I think, okay, it's not part of this. But for example, the simplest way we can differentiate these two is that for T1 weighted images, everywhere where there is accumulation of fluid has a low signal intensity. Fluid is hypo-intense. It is black on T1 weighted sequence. So wherever there is water will look black on T1 weighted. Whereas on T2 weighted sequence, wherever there is water, it is going to be white. Okay? That is one very simple, crude way of differentiating T1 weighted sequence from T2 weighted sequence. Then there are other common areas, tissues that we also look at. For example, on both T1 and T2 weighted sequences, fat looks bright. Fats look hyper intense. So just by looking at this fat here, is the fat in the subcutaneous tissue, we cannot differentiate whether it is T1 or T2, because we have already said fat is bright on both sequences or hyperintense on both sequences. But when we look at the urinary bladder here, we see that the urine is not black, it is bright. So it means it cannot be T1, but it is T what? T2. So that is how we play about with the MRI. The rest of the things we have already discussed before. These are how we approach abnormal situations, but I think we may have to stop here. Are you already tired?
Yes,
No.
it's already past time, doctor.
It's already past. Because I see our numbers dropping. So let me just look through the charts if there are more questions in there. We see how to address them. If not, then we call it off.
Doctor, maybe also the PowerPoint for the previous introductory notes.
I think you'll have to provide an email, then I can send.
Okay, should I drop it in the chat, Doctor?
You can send it to me either on WhatsApp or
Message.
SMS. Yeah.
Okay, Doctor. Thank you so